Dr. Jay Hertel, welcome to the Physical Performance Show.
Great. Thanks, Brad. Great to be here. Thanks for the invitation.
Jay, I was mentioning off air that here in Australia, I'm undergoing a specialisation training program for sports physiotherapy. And one of the key areas, of course, is dealing with ankle sprain injuries. And your 2019 updated model of chronic ankle instability was quickly and early put up in lights for us as a great framework of how to clinically approach lateral ankle sprains and their possible sequelae in practice life. And I can't tell you how many times I've listened to you on the In Performance podcast. I've read that paper, but I feel like it's finally starting to gel. And the hope today in having you on the show is just to be able to pull from your wisdom and your knowledge for the athletes, the practitioners out there, and how to better manage what can be very real sequelae from lateral ankle sprains. So I guess starting at the top, what spawned your interest in this line of research in lateral ankle sprains?
As is commonly known, ankle sprains are really common, right? And when I was, starting my career as an athletic trainer here in the U.S., ankle sprains were the most common injury that I was seeing, kind of regardless of what sport we were dealing with. And when I had the opportunity to begin doing some research for my master's thesis, it just seemed like a real, logical area to try to learn more about, and just kind of took off from there, and I've never really stopped doing it. And I think we've made some great progress, but unfortunately, the injuries still happen a lot, and there, like you said, there's complications that still occur.
So, in terms of statistics, Dr. J, I've heard you cite circa 50% of patients or athletes, I should say, that sprain an ankle will incur another one.
Yeah, so definitely, the most common risk factor for incurring an ankle sprain is having a history of one. So I think that right there says what the one of the problems is, and unfortunately, as more and more sprains add up, you have the potential to damage other tissues around the ankle, and to develop some chronic problems that are more than just an ankle sprain, if you will. That you can end up heading down a route where the ankle starts to degrade, and early onset osteoarthritis in people who seem like they're too young to have that.
Yeah, gosh. It's something I think early in my clinical career, Jay, you might have assumed could happen, but I think I'm 44 now and I live with some kneecap osteoarthritis.
Yeah.
And it's really changed and seen patients over the years who maybe were a bit laissez-faire about their ankle sprain chronology, and then they get into their 40s or even earlier at times, and they're really struggling with subtalar talocrural joint osteoarthritis, and the results can mean surgery and a very marked change in lifestyle.
Yeah, absolutely. And I think when young, otherwise healthy people incur an ankle sprain, the standard response to that is walk it off, try to get back as soon as possible. Unfortunately, I think we're seeing that there are some challenges to that, and that I think if a lot of people, when they have that first ankle sprain, if they find out that hey, 2 years after someone's first ankle sprain, 50% of people still have at least one symptom. I don't know that we do a great job of telling athletes that, and that this is really something that you need to stay on top of. And I think it's the answer isn't just sitting out longer after ankle sprain. I think it's really doing what can be done to prevent those secondary sprains, and getting somebody to have a stable ankle in the long term is I think a more realistic goal.
It's quite, you mentioned stable ankle, and it makes me think of how we treat ACL injuries. Everyone's
Yeah.
quick to jump on it, make sure best practices are adhered to, minimize impairments. And I think we still have a long way to go. But the works of like yourself, Jay, help to bring to the fore that the impairments, the symptoms after an ankle sprain can be many and varied. And your work tells us that 4 out of 10 patients that incur one ankle sprain will go on to have chronic ankle instability. Can we wrap some sort of understanding, Jay, around what that means, chronic ankle instability? And you
Yeah.
mentioned symptoms. What are the symptoms, for example?
Yeah. The symptoms that we're typically seeing are continued pain, swelling, reduced range of motion, reduced strength, but probably the biggest one is the sensation of the ankle giving way. One of the favorite analogies that I've heard is, people with chronic ankle instability feel like they trip over the flowers in the carpet, right? That they're walking on a perfectly flat surface, but they feel like their ankle can give way without it, actually, um, you know, re, no perturbation or anything like that, right? So from a time perspective, what we typically do is to say that, if somebody's having those symptoms and it's over a year from their first ankle sprain, that they then have chronic ankle instability. We like to think that within that year of the first sprain, that there's actually a time there where they that's where rehabilitation is going to work best. And it's not to say that it can't work further down the line, but to really, if you can get athletes in particular through the first year after their initial sprain, if they can go a year without having a recurrent sprain, their risk of re-injury actually is back where it is for athletes without any previous history of sprain. But in that first 6 months after first sprain, the chances of suffering another ankle sprain are really high. And then that 6 to 12 months, it's still elevated. But if we can get them through 12 months, that's um, I think the time period where you really want to focus your prevention initiatives, both in terms of rehabilitation and therapeutic exercise, but also I think in terms of, bracing and taping as well, that's the period that you can do the most benefit.
So 0 to 6 months post the index or the initial lateral ankle sprain episode, heightened risk, 6 to 12 months, less risk, but still risk. But if you can get out to 12 months and celebrate the 1 year anniversary, that
Yep.
overall risk has really come down back to a baseline.
Yes.
I was sharing this framework with a local foot and ankle orthopedic surgeon, and their question to me was, why a year? If someone's struggling, we may become aware of that a lot sooner. And I resonate with that clinically, of course. But was there anything about the 12 months? Was that research led or more of a clinical framework, Dr. J?
Yeah, so that specifically came out of a research study where I think that, we count things in months and years, and that is when you kind of say as well, how are the people doing it 1 year? How are they doing it 2 years? Kind of thing. So
Yeah, yeah.
so yeah, so I don't know that there's anything magic about 365 days, but just in general, I think that's a good way to think about it.
When a ligament is disrupted, Jay, there's more than just mechanical impairments that result. You mentioned this in the paper. Can you just speak to that? I've heard Stephanie Philbay talk about this with the ACL, that there's a naivety to think that you can put another ligament, an artificial ligament in it. It's going to behave like the organic biological tissue. So, can you talk to the wonders of these ligaments and what they actually do?
Sure. The main substance within ligaments is collagen, right? Which is a connective tissue that, is there to hold the bones together. But ligamentous tissue is also very well innervated. So it has a high density of neural receptors. And, a lot of times we focus on, so-called proprioceptors, really being receptors that can sense lengthening of that ligament, can sense pressure, both from outside the joint and also inside the joint. And what happens when there's structural damage to the ligament is it's not just the collagen that's disrupted, but those nerve endings are disrupted as well. And there's a sensory deprivation that happens after injury. And we all know that the sensory system is connected to the motor system, right? So that when you know you have, let's say, swelling that occurs after ligamentous injury, especially if that swelling's within a joint and a fusion, then that's starting to put pressure on the joint capsule and the ligaments around, and that's going to oftentimes result in motor deficits, right, through a reflex arc. So a lot of times we describe it as like arthrogenic muscle inhibition, but that idea of like a ligamentous tissue can be injured, but yet there's also muscular consequences to that as well, even though the muscle or the tendon weren't themselves injured.
It's that flow on sequelae, as you say. I think it's yeah, it's important to recognize that both as athletes and practitioners, that it's not just about the mechanics of the tissue. It's all these other interrelated systems, which your paper gives this, the updated model gives this nice framework. And I have to admit, when I first looked at this and first read the paper, I was a bit overwhelmed. But as I've spent more time around it, it's actually beautifully simplistic. It's just understanding the principles.
Yeah. There's a lot of circles and boxes on there.
Yeah.
I will admit, but yeah, and I think really what we tried to do there is to show the interrelationships between the structural damage, the sensory side of things, the motor side of things, and then also pulling in other things we know about viewing healthcare like through the biopsychosocial model of saying, well, what's going on around them is going to affect how they best respond to treatment or what treatment might be best for them as well. So kind of have a background in clinical biomechanics, and I always like to say, like, let's make sure we keep the bio in biomechanics. I think that's really important. But, from the clinical side, we can't ignore the psychosocial aspects either. So they all have to work together.
And in the paper, you reference the psychosocial factors as personal factors on one side, the demographics, the medical history, the physical attributes, the psychological profile. And then on the other side, you've got the environmental factors, home work considerations around transport, stairs, social support, access to services, and the demands of the sport, the aspiration of this athlete in terms of their sporting pursuits. These are all moderators, contextual factors that will then influence what impairments get spat out after the injury.
Yep, absolutely. And I think what we're really looking there is to make sure that clinicians don't get too focused on just like, oh, I have to worry about the range of motion and the strength. All those things are the balance. All those things are important, but also remembering, not all patients are bringing the same thing to the clinic, nor are they leaving the clinic to the same situation. So.
Yeah, that's great. One thing this framework has helped me with, Jay, is when a patient presents in clinic with a lateral ankle sprain injury, is just having that framework to go to in my assessment to think, we'll talk about these in a moment here, but pathomechanically, what impairments might I find? Sensory perceptual wise, what might I find? And then on the motor behavioral side, what might I find? And I sort of just break it into the three categories, and I go fishing for what I can find. So can we speak to these groupings? But before we talk about the three groups, I found it really interesting listening to you speak and reading the paper about some of the evolution of getting to this point. And
Yeah.
you reference like Hans Trope and Freeman and these prior researchers. Can you just speak to that little journey quickly to get to the point of where we're up to now? Uh, how did that evolve?
Yeah, absolutely. So when you go back and say like, well, who really, first hypothesized about sensory motor deficits or neuromuscular deficits following joint injury, and it was a British physician, Freeman, who put out a series of papers in the mid 1960s that actually included like some animal model with like some studies of cat hind limb joints and what happens when you severed ligaments and what happened to the muscles around it. But also, he was really the first one to report in the medical literature about balance deficits after ankle sprains. Um, and the fascinating thing to me is those papers really didn't get cited again until like the 1980s. So they went almost 20 years with very little notice. And then in the 1980s, Hans Tropp, uh, who is a Scandinavian uh, physician for his doctoral thesis, kind of followed up on some of this uh, balance deficits, and then he was the first one to kind of put out the idea of, well, there's mechanical instability and there's functional instability, and he was using the term functional instability to really describe like sensory motor deficits, and then obviously the mechanical instability was the joint laxity after certain ligaments are sprained or ruptured. Um, and obviously there had been technological changes, right? Like force plates and the ability to have an instrumented measure of balance kind of came of age in the late 70s and early 80s. So now all of a sudden, here's this tool that we can measure balance with, and then it just kind of took off from there. Um, when I was doing my graduate work in the late 1990s, I went back and was reading some of those papers. One of the things that I struggled with was this notion of functional instability as the term for like the sensory motor deficits, because I'm kind of like, well, what ankle instability presentation isn't functional, right? Like, because just functional testing, and I just didn't like the terminology of that. So, I was a brash young person in my mid 20s, and I'm like, I'm just going to start calling it something else and see if go with it. And wanted to really kind of make the view that the term chronic ankle instability was better descriptor of what the long-term problem was, and that what you really had was different types of impairments. Some of those mechanical that were on mostly on the laxity side, but also could be related to like diminished range of motion and things like that. And the functional impairments are really sensory motor and neuromuscular impairments. So I wrote a paper in 2002 that kind of laid out that first model. It was well received, and a lot of people read it, a lot of people cited it. Um, but then, as my career evolved, the great thing was there was a lot more research being done on ankle sprains and ankle instability. And I got to the point probably around like 2015 where I'm like, I feel like there's enough new information that we actually know more, and that the 2002 model could be evolved, and that's what ended up being the 2019 paper. And just while we're I'm doing this podcast with you down in Australia right now, I actually kind of workshopped this at one of the Sports Med Australia meetings. I don't remember what year. I'd have to go back and look at on my CV, but Luke Kelly had invited me over to talk, give a couple of talks at the Sports Med Australia meeting, and I kind of had this idea. I'm like, I need to talk to people about it and get some feedback on it. And I actually did that at that meeting, and really helped everything come together after that. We kind of finalized it and wrote it up.
Gosh, so there was a bit of an Australian input to this framework.
No, absolutely. One of the things that's been great is that there's a conference that I helped to found called the International Ankle Symposium, and it's actually been held in Australia twice. I think Kathy Rifsoggi and Claire Hiller at the University of Sydney have been involved with that. Bill Vicenzino and Michelle Smith in Queensland. So, and it's been great because that conference is usually held every 2 or 3 years, but it's also created these great international collaborations and things. And the next version of that conference is actually going to be in Seoul, South Korea, in November of 2026. So if people want to keep their eye out for that, that is always a great meeting.
Got a year to get organised, Jay. And I think it's nice to hear some of that background because I'm a full time practitioner, but it's works like this, and then the integration of those into practice, the dissemination of the literature that gives you the confidence to stand in front of your patients and ultimately hope and try your best to do so, provide the best care you can. So this paper has helped me better serve patients at presenting clinic with ankle sprain injuries. So I think it's nice to hear that there's this collaborative effort around the world, International Ankle Symposium, and people aren't sitting on their hands; they're trying to push it forwards ongoingly.
Yeah, absolutely. And I think that, that the my goal with the updated model was not just to kind of explain this um, you know, physiological system, but really to be like, how can clinicians use this model in clinical practice, and kind of this idea that, you know, assess for these different impairments. Not every patient's going to have every impairment, so find out which ones are most uh, affected in an individual patient, and then build your treatment goals around your assessment. And which is not a novel idea by any means, but it can be overwhelming when you go into the ankle sprain and ankle instability literature and see like, oh, there's balance deficits, there's strength deficits, there's gait deficits, there's all these different things. And but recognizing that like not every patient is going to present with all of those. So you don't have to fix 20 things. It's like find the 3 or 4 things that are most uh, apparent in the individual patient and address those.
Yep. So you go hunting for the impairments, they become your treatment targets. Start with the obvious and the bigger, if you like, impairments, and go from there. Jay, I think it'd be really rich to just touch on the little circles in the big circles and work through the model just to help bring it to life, if that's okay. So an athlete incurs an index injury, a lateral ankle sprain. Typically, it's probably going to involve the ATFL ligament, sometimes the CFL, and then they're going to have impairments, and they're in 3 buckets: the patho-mechanical, the motor-behavioural, the sensory-perceptual. Let's talk about the patho-mechanical, uh, pathological laxity. Can you speak to that, Jay?
Sure. So that right, ligaments' main job is to hold bones together, right? So when you have structural damage to that, the ligament is going to have what medically we call laxity or looseness of the ankle, and in certain directions it's going to have more motion, and that's the characteristic sign, right? And we would love to have the ligament heal back together perfectly and not have any residual laxity, but in reality that doesn't happen a lot of times. And you kind of have to weigh like, do you really need to immobilize someone for weeks or months to try to get that ligament to scar down, versus the more functional treatment that we have. People can recover from them sooner, but I think one of the consequences that happens is residual laxity is relatively common. It's not the end of the world, right? If someone has extreme laxity, they're a surgical candidate. That ligament needs to be repaired or reconstructed somehow. But if they have mild laxity, most people can train their sensory motor system, the muscles and tendons that cross the ankle joint, to provide secondary stabilization and be okay. And that's what we really try to do in rehabilitation.
Yeah. I use an analogy in clinic, Jay, with, as you just said, that laxity, that looseness. It doesn't really restore to the ligament per se, but of a water level in a pool, and now your water level's reduced, and the rehab can try and help get that water level back up. And I think some sort of illustration help people appreciate that. Arthrokinematic restrictions, big term. What does that mean, Jay?
Yeah, so this is the idea. So arthrokinematic means movement of the joint. What we're really thinking about here is the subtle movements of the joint. So, for example, in order to dorsiflex your foot, to have your top of your foot come up towards your leg, the talus, one of the main bones in the ankle, has to slide backwards or posteriorly on the tibia to allow the foot to dorsiflex. Now, usually what happens when someone sprains their ankle is they actually can pull their talus out too far forward. So we kind of get this paradox where it's loose this way, but it doesn't move enough that way. And a lot of times when we actually have range of motion restrictions after ankle sprain, we have to work on those subtle movements. So in that case, like doing some manual therapy to get some posterior glide of the talus and restore that motion to allow the larger motion of the foot on the leg. So
Yep.
that's just one example. We also see that at the inferior tibiofibular joint as being a common site as well, and obviously that's connected to the proximal tibiofibular joint. So you can keep going
Can
around.
you
So
just speak though to that inferior tib fib joint there, Jay? Like what can happen there post lateral ankle sprain?
yeah, so I think what's interesting there is you kind of actually get this sense that the lateral malleolus, the distal end of the fibula, can actually kind of slide forward a little bit anteriorly and then kind of get stuck in that position, and that creates a little bit of a problem because it's almost like you're making the anterior talofibular ligament kind of slack. So then, when you get more motion of the talus, it can move further and stuff like that. So a lot of times, doing posterior mobilizations of the lateral malleolus is really beneficial to actually, are we putting it back in place? Maybe, you know, or are we just kind of restoring that subtle movement there that allows for normal movement between the joints?
And is there any relationship with that, Jay, that bottom or the distal end of the fibula with what happens to the talus with the inversion or the rotation, which I've heard you reference that we have to consider that rotary movement of the talus post ankle sprain injury?
I I mean, it's possible. The challenge is really hard to measure. Um, but I think certainly when you look at the arthrokinematics, to me, it's all about those small, subtle relationships between the different bones in the ankle complex. So yeah, I think certainly that, just because we call it the tibiofibular joint doesn't mean those are the only two bones involved when something happens at that joint. So that the talocrural joint can certainly be affected as well.
And it's just a clinical example, Jay, that I think brings to life how these seemingly small, inconsequential impairments can sometimes get missed and have ongoing effects. We had a Australian representative, 100-kilometer road runner here in Australia, who was getting marked pain in his lateral calf and also some dysfunction up in the hamstring to the point he wasn't able to finish these representative races. He would have to, he had footage of his run in. I was certainly scratching my head. I was actually thinking he might have had a neurological condition that was starting to present. And I sent him to one of our great Australian specialist sports physios for a review. And Andrew picked up that he had a stiff tib fib joint, probably secondary to some prior ankle sprain injuries, and simply mobilize that, as you just said, posterior gliding on that distal tib fib joint. And this runner has not had an issue since. He has to keep that mobilizing up. Plus, he's done a lot of stability work for his ankle. But this was it's probably the most profound example of that I've ever come across in 20 years of practice.
Yeah, yeah. I mean, it's really fascinating how you can have someone who is by all accounts an elite athlete, and that just a small kind of mechanical situation can really have effects that affect the whole limb. So
Yeah, no, and absolutely. And osteokinematic, we're talking about these pathomechanical impairments. We're doing a bit of a race through these osteokinematic restrictions. What does that mean, Jay?
the biggest thing that really means is you know limitations in dorsiflexion or plantar flexion motion, inversion or eversion motion, and certainly dorsiflexion is the most common that we have, and we kind of talked about the arthrokinematic component to that, but then we also have to think about like the flexibility of the gastroc complex and the Achilles tendon um, as well. So yeah, so we're talking about the larger motion of the foot on the leg. Yeah.
Secondary tissue injuries, what can they include?
Yeah, so I think this is what happens when you start to get those recurrent sprains. That it's not just the lateral ligaments that are getting damaged, but so certainly you can have the possibility of like osteochondral lesions, so that as the talus is slipping out, that it's actually like banging on one side and loose on the other, where the talus going into the tibial plafond can be a problem there. Um, Sinus tarsi syndrome, so basically like just an inflamed synovial tissue in the sinus tarsi. We can also start to get like either perineal tendon lesions or the retinacula, that connective tissue over the top of the perineal tendons, kind of holding them in place, that we can start to see problems with that. And if you've got someone with lateral ankle instability and they're getting a lot of clicking on the outside of their ankle, a lot of times they've torn their retinaculum, and one or both of the tendons are actually slipping over the lateral malleolus.
So there's other structures to consider apart from the local tissue injury site. And tissue adaptations, this is the final small circle in the bigger circle, or the bucket of pathomechanical impairments. Tissue adaptations, what might that include, Jay?
Yeah, I think that one gets really at like that sinus tarsi irritation, and the synovium starts to expand out with scar tissue, and it just kind of gunks up the joint.
Okay. So like some hypertrophy of the synovium and thickening, etc. And I know I just spent 2 days in Australia with Australian ballet physiotherapist for 30 years, Sue Mays, who was taking practitioners through the impact of ankle sprain injuries. And she was very specific to point out that don't forget about these adaptations that can occur after ankle sprains, synovitis, the subtalar joint, effusions, etc. So I think that's really handy to keep in mind. Jay, let's go from which bucket do we want to jump into next? Sensory perceptual?
Yeah, let's do that one next. So
Diminished sensation. What does that mean?
yeah, basically thinking about proprioceptive uh, deficits, and that those are most often thinking about not being able to sense exactly where in the joint's range of motion it is, or also to like be able to sense like how fast the joint is moving. And when we talk about like proprioceptive deficits, we have to remember that like proprioception is a sensation. So that's why this is all like on the sensory side. We'll get to the motor deficits, the more of the muscular stuff on the other side. But this is, I think, a direct result of those neural tissues being damaged, those neural receptors within the ligament being damaged at the same time that the collagen and the structural damage happens.
You made me think there's speed and positioning for these proprioceptors. Kind of forget about speed.
Yeah, yeah, and I think that when we get to rehabilitation, I think we have to think about that, in terms of like, that slower controlled movement that you might have of just stand on one leg for a balance exercise. you know we really need to, get some perturbation in there to get the joint moving at a faster velocity.
Yeah, to restore some of that lost capability. Pain, I mean, that's fairly evident and obvious, isn't it? Soreness.
Yeah, yeah, but
Maybe I'm missing something.
yeah, well, I think this is an interesting thing. Where I actually have people that asked me like, is chronic ankle instability a chronic pain disorder? And my answer is, in most people, no. I don't think pain is their biggest symptom, but in a subset, it could be. And again, that gets down to talking to your patient and finding out what are their biggest complaints. Because if it is, pain, then I think you've really got to, focus on that during your treatment and make sure that, what you're trying to do from like a therapeutic exercise perspective isn't, hurting them.
I think that's key to point out, though. Misunderstanding that patients, athletes, the public may have is chronic pain, chronic ankle instability. This must be relating to someone that has ongoing pain. But no, we're talking about ongoing laxity, real episodes of instability or perceived reduction in quality of life, reduction in sports participation. It's bigger than just pain. Perceived instability. Anything you'd like to say to that, Jay?
Yeah, that really just gets at the fact of like, does the person sense that their ankle is unstable? Do they have confidence in the ability to do things, even just walking on uneven ground or something like that? Perception that my ankle's not right, I think, is really important.
The perception that my ankle's not right. Yeah, like you said, the tripping over the flowers in the carpet.
Yes, exactly.
Kinesiophobia. The practitioners listening will be most likely aware of that term. To the general population, athletes, what does that mean?
Yeah, so it's really it's the fear of movement, and it's the fear of re-injury, and just this idea that after the first injury, or the fifth or the sixth injury, of like, does a person really start to like be guarded with what they're willing to present themselves with, and be like, oh, I don't do that anymore. um and part of this is just the sense of like, does the patient think they can get back to where they were before or not? Do they view it as like, oh, because of my ankle, I should no longer do those things?
Yeah, such an important point. I depending on the patient, but I may at times use like a patient reported outcome measure to capture that in the patients that present with some ongoing concerns after their ankle sprain injuries. And I found that clinically to be helpful.
Yeah, absolutely. I actually just taught about this today in a class of first year athletic training masters students. We were talking about different patient reported outcomes, and we talked about some different kinesiophobia, or re-injury anxiety type measures that can be helpful. That sometimes the ability that you can ask a patient and get a response, but sometimes putting 6 or 10 questions in front of them, you're unlikely to ask all those questions just in the regular course of practice. But when you do get that many responses, you can see some patterns sometimes that you're like, okay, we need to work on this. And I do think that the phobia, right, makes it sound like it's this big disorder, but a lot of this, I think, is confidence, right? And it's building the confidence. It's exposing them to say, see what your ankle can do, in a controlled rehab setting. Get them confident in that, so they can go back to their sport, or to whatever physical activity they do.
Yeah, confidence. It's something, I think it's a good question to ask. How confident are you at the moment with this as a percentage or some other metric? But I think thinking about the populations we're talking about here, often athletic people, they like games, they like numbers, and so I found it clinically. You get these scores through these outcome measures, and it's a game. Then the race is on to try and hit a target, and because some of these impairments are kind of invisible. And so I think it's nice. What other outcome measures in that kinesiophobia category might you suggest, Jay? Obviously, the Tampa questionnaire?
Yeah, the Tampa scale of kinesiophobia, I think, is a really good one. I think the other one there's one. Oh, you're gonna catch me on the.
No, it
It's
wasn't a trick question.
it's like the injury psychological response. I would have to get the exact letters, but there's definitely an I and a P and an R in it. But what I like about that particular one is there's only 6 items,
Yeah.
so it's just short and sweet,
Yeah.
which I think is good.
Yeah, great. We'll look that one up and pop it up in the
Yeah,
show notes,
sorry,
Jay.
sorry it wasn't
Uh,
right at the top of my head.
no, that's fine. That was not a catchy question. Lower self-reported function. We're talking about these sensory perceptual impairments. What does that mean?
Yeah, I think that's the notion of what do they sense that they have problems with, and being able to kind of work through different types of physical activity situations, from activities of daily living that might be things, like squatting or walking, for certain amounts of distance or time, but then also like on the sports specific side in terms of how do they feel about jumping and landing and cutting and agility work and things like that. And kind of my go-to assessment there is the foot and ankle ability measure, so the FAM, which has a separate activities of daily living scale, that has about 20 questions on it, and then a sport subscale that has like 8 questions on it. And I think that sports scale um, really works for almost any weight bearing sport, in terms of the activities that they're picking up, and for terms of jumping, landing, agility, stuff like that.
In your paper, I think, correct me if I'm wrong, gives a guideline there for the FAM, the foot ankle ability measure for sports, the sports domain, less than 90% and less than 80% for the ADL, activities of daily living subset. Is that
Yeah,
correct?
it's actually the opposite. It's less than
Okay.
90 on the ADL and less than 80 on the sport. But the reason for that is there's a lot more questions on the ADL one, so the denominator's bigger. So
Yeah.
yeah,
Okay.
that
And then the other,
research answer there. So
what was that? Sorry, research.
the
That's good.
research team,
The details matter. And then, if we're talking about numerics for the continuum of outcomes, the chronic ankle instability patient, the Cumberland ankle instability tool, I think, is also something that you cite in the paper with a cutoff of less than 24. Is that correct?
yes, yeah.
Yep. And that's an easy to use one I find in clinic.
Yes, absolutely. I really like that on the screening side, but it also works well as a outcome to track patient improvement.
And the last little mini circle in the bigger bucket or circle of sensory perceptual impairments is reduced health reported quality of life. Just a questionnaire there, Jay, or anything you'd like to add to that?
Yeah, so really just thinking about getting away from the joint specific or the limb specific measures, and more so just about like, is their ankle injury causing them issues in terms of their social expectations, whether that be sport and exercise, whether that be work, whether that be family? How's it, affecting, just someone's overall vitality? Do they, have some anxiety or depression related to their injury, and things like that?
Yeah, okay. So the ankle is attached to a human being. Let's
Absolutely, you cannot forget that.
And Jay, so we've covered two buckets: the pathomechanical bucket, the sensory perceptual bucket, and then we've got this big bucket: motor behavioral impairments, altered reflexes.
So this is, kind of where the sensory and the motor come together. But when we assess reflexes, we're almost always assessing the motor side of that. So I think we get that, and we most commonly think about that as, somebody with chronic ankle instability. They can't sense their ankle rolling fast enough to get a reflex response to stop that from happening. And I think that's the biggest one there, that we just see of, that kind of stretch reflex is broken.
The stretch reflex is broken, so yeah, that makes sense. They can't sense their ankle rolling fast enough to get that reflexive response from the muscles that may help prevent them in going over. Neuromuscular inhibition, you did touch on that earlier about the arthrogenic muscle inhibition, that you can have a joint injury that then produces impairments in the surrounding muscles.
Yeah, and what we're typically most concerned about here are the the peroneal muscles on the lateral side of the ankle, so peroneus longus and peroneus brevis, which really help to protect the lateral side of the ankle as secondary stabilizers. But there can also be more proximal deficits as well. We see a lot of individuals with chronic ankle instability that have hip abductor weakness. We might think about gluteus medius and things like that. And that's a tough one to work through the neuro, like how that happens. But is that something you see in your practice of hip weakness or inhibition in folks with ankle problems?
Yeah, I think it came on my radar. It might have been through the paper. And from time to time, I might check it. But I'm certainly mindful that, as you say, it's not just below the knee. You need to also consider above the knee at times. I always think of Jill Cook's teachings with tendon pain, how it's, you've got a sore Achilles tendon, you better be looking at the calf, the quads, the hamstrings. So I think it's, probably along those lines, Jay. Muscle weakness probably goes without saying, doesn't it?
Yeah, yeah, absolutely. And I think that, it's not just that the electrical activity of the muscle is inhibited, but it's actually the muscle produces less force, and that uh, is obviously problematic in terms of the musculotendinous units providing that secondary stabilization.
Yep. And with the advent of like handheld dynamometers and that in clinic, I think it's really a nice part of helping the athlete buy into minimizing their ongoing risks, to be able to see the numbers, right? Look, there's your score, track it, come back, show me better next time. And so I think we're in a golden age of being able to actually quantify these things. And I mean, you can still do the good old manual muscle tests as well, right?
Sure, sure, absolutely. And yeah, and thinking about not just eversion, but like eversion and inversion, and what are the ratios look like there? Same with like dorsiflexion and plantar flexion as well. That we can't just assume, oh, it's all an eversion strength
Mm.
problem.
Yeah.
Make sure you're working all the directions of the joint.
Great tip. Balance deficits. And then there's only two little mini circles to finish with here. So, balance deficits, Jay. Anything you'd sort of point out to the practitioner or the athlete about that? It seems fairly obvious, but there's a bit more to it, isn't there?
Yeah, I think when we look there, we have to be concerned with both what we may consider static balance deficits. What we mean there is the instruction given to the patient is stand as still as possible on one limb, and that's certainly a good assessment and a good rehabilitation strategy. But then also thinking about dynamic balance. Can the person balance on one limb and dorsiflex the ankle and flex the knee and flex the hip? Can they get some movement of the trunk or movement of the other limb as well to kind of create some internal perturbations there? But the balance deficit's another you wonder. It's really putting the sensory and the motor together, but we end up measuring the motor side of things.
Yeah. Okay. Great. And altered movement patterns. What does that pertain to that we haven't captured already?
Yeah, so this is one where I think we're looking at when people with chronic ankle instability walk and run, they tend to have their ankle in a more inverted position on steps where they don't turn their ankle. This is happening both in the swing phase as well as in the stance phase of gait, where they're keeping weight on the outside of their foot more. This is really an issue I think that stems from, well, the ligament is damaged, so that mode of joint stability is compromised. The neuromuscular system is damaged, so your secondary stabilization from muscles and tendons is damaged. So what you have left is to go back to the bones. And if you think about the most stable position of the talocrural joint and the subtalar joint is going to be in a supinated position. And that's going to end up with the foot, like during stance phase, they're going to bear weight on the lateral side of their foot. They're not going to pronate as much because they don't want to let that whole foot relax because they have a sloppy ankle and it's just not going to do it. So they almost stay rigid intentionally, which I think is a really clever response to the ankle instability. But the problem is they're on the outside of their foot, so they're closer to rolling over. So I think that those things are all kind of connected. And we've also done studies where we've shown that, like on jump landings as well, especially when we start to do like some unanticipated landings and things like that, that people with chronic ankle instability, they're hitting the ground in a more inverted position, which obviously is pointing them towards a lateral ankle sprain.
Yeah. So, and I think that acknowledgement from the paper has made me in clinic take a closer look at people's gait, have a look at how they're walking, how they run in, looking for that very mechanism that you just shared, because that would heighten risk and also potentially that lateralization of pressure on the foot in achieving that position can then play out in other ways, right, with secondary consequences. And
Yep.
then, Jay, the reduced physical activity, I found this, and I've heard you talk about this, quite fascinating, but also quite maybe alarming is not the right word, but
Yeah.
there's very real reduction in activities at times.
Yeah. So one of my former PhD students, Trisha Hubbard Turner, did a study where she took college students who had chronic ankle instability and age and sex matched college students that had no history of ankle sprain, and basically just had them wear accelerometers for a week during their normal activity, and found that the group with chronic ankle instability took over 2,000 less steps per day. So these are otherwise healthy 20-year-olds, right? The only real difference between those two groups is the ankle sprain history. And, you add 2,000 steps a day up over a week, over a month, over a year. That's a lot of physical activity. I think there's some, you know, metabolic concerns that start to happen that we can't just ignore this.
Once again, it's more than just an ankle sprain. We need to look at this thoroughly, systematically, identify impairments, and try and get to that 1 year anniversary.
Yeah, absolutely.
Jay, is there, before we do our final set questions, which every guest of the show has been thrown over the last 9 years, is
Yeah.
there any further ins to the model? This was 2019. We're recording in the calendar year 2025, but is this something that you'll continue to further on with the International Ankle Symposium, or have you got some other projects on the go at the moment? I'm sure you do.
Yeah. Yeah, really where my focus now is it's just trying to optimize rehabilitation. So like we just finished a study where we're comparing two groups of young adults with chronic ankle instability, one that did kind of your traditional neuromuscular rehabilitation, and then the other group uh, did that, but then we added in um, uh, a real robust intrinsic foot muscle um, uh, exercise program as well. Kind of along the idea of, we were hypothesizing if we can improve the base of the foot, will the ankle be more stable on top of that? So we just finished the rehabilitations on those. We're in the process of collecting our outcomes, and we'll do a 6-month follow up on those folks. So I don't have results for you yet,
Oh,
but that's really where I'm at right now is more about like how can we actually optimize rehabilitation?
I mean, it makes sense intuitively, doesn't it? That if you can improve the base through some better foot functioning, then that
Makes sense to me.
it makes sense. But let's see.
Yeah.
We'll be holding our clinical breath for the results of that trial, Jay. Jay, every guest of the show gets asked two set questions. The first being, if you could boil everything you've learned through your academic career, your professional career, into one piece of advice to help listeners of this show perform at their physical best, it doesn't have to be ankle centric, what would that one piece of advice be, Dr. Jay Hertel?
I think it would be to make sure that you find joy in what you're doing, and that you know the term like exercise is medicine, that's really clever, but like not everybody wants to take their medicine. So I want to make sure that when we're working with patients or working on ourselves, and to not think of like exercise and needs to be a burden that needs to be completed, but to make sure that there's joy uh in it, and that hopefully that can come through some type of sport or exercise in a social situation, or even if it's just by yourself, having that, hey, I've got my 45 minutes and I'm going to go on my run, and that's my thing, is making sure that a person finds activities that they enjoy.
Yeah, wow, that's profound, but beautiful in its simplicity. And then Jay, every guest of the show issues listeners with a physical challenge for the week. So you can be really nasty here, or really kind, or anywhere in between. What's Dr. Jay Hertel's physical challenge to the listenership going to be?
Yeah, so I'm actually going to go to the intrinsic foot muscles and say to get good at toe yoga, and the ability, let's say, to keep your lesser toes on the ground while you extend your great toe. Do that like 10 times without moving your lesser toes, and then vice versa, keep your big toe on the ground and lift your lesser toes up. Do
Trying to do it
that.
with my fingers, and yeah,
Yeah,
great. So toe
exactly. So
yoga.
that's my challenge. So it's more of a coordination, motor learning challenge. How about that?
Yeah. And I think it's the first time that's popped up, Jay. So I think that's a nice challenge that'll engage the listenership. Jay, uh, is there anything the show can do to help you with your academic pursuits? Do you need subjects in any direction, or any events or anything coming up apart from the International Ankle Symposium you mentioned in 2026 in Seoul?
Yeah, that's the big one, in the ankle instability world that we're doing every few years. But at this point, I don't have anything specific, but I would just say, don't be afraid to reach out to other clinicians, to researchers, and ask them questions. Like, we're not doing this stuff just to like publish papers. Like, we actually want to help people, and it's the clinicians that are working every day that are doing the most help.
Jay, thank you. Best way to reach out for you, we can put this in the show notes, but is there any preferred method for those that did want to reach out?
Yeah, I'm actually kind of less active on social media than I than I was there for a while. So email is the best way. So just the letter J, and then my last name is Hertel, Hertel, at virginia.edu.
Thank you very much, Jay. We'll pop that in the show notes. And thanks for your contribution in this space. That's a clinician talking, thanking you for making my life more structured and easy when it comes to helping athletes with these injuries and patients. So thank you from me, and thank you also from the collective body of clinicians out there. And wish you all the best leading up to the 2026 symposium.
Great. Well, thank you very much. It's been a real pleasure talking with you today.
Thanks, Jay.